It's very strange sitting here talking to a mic that doesn't microphone, but anyway, we'll manage. I've got 3 case discussions to go through with you this morning that illustrate some of the important aspects of managing ladies with rheumatic heart disease in pregnancy. Though, first thing I'm going to do is just spend a few minutes outlining with you what's actually normal in terms of cardiovascular changes in pregnancy, because in order to really understand why people with valvular heart disease struggle in pregnancy, you need to know what actually happens to the heart in normal pregnancy. So these are people with normal pre-existing hearts, the changes that happen when they get pregnant. So it's normal to get a 50% increase in your blood volume and cardiac output. Can you see? Yeah. During pregnancy, and that goes along with a reduction in systemic vascular resistance. So the pipes get wider is the easiest way of thinking of it, so there's less resistance to blood flow. That's what contributes mostly to the normal fall in blood pressure that we see, particularly in the first trimester and into the second trimester of pregnancy. So that's all normal. And then after delivery, as the baby is removed, you get increased venous return. Basically, it's mechanical. You haven't got the baby pressing on the inferior vena cava in the abdomen anymore, so you get increased return of blood to the heart. So those are all the normal changes that occur to the circulation during pregnancy, and they can actually last for about 6 months after delivery. It's a combination of an increase in heart rate and stroke volume, the increase in cardiac output. You also get an increase in plasma volume during pregnancy. That's normal. It can increase by about 50%. That's what contributes to this physiological anemia that most women get during pregnancy. Their red cell count actually does increase as well, but not as much as the plasma volume. So that's really one of the reasons that people do get anemic during pregnancy. Giving iron supplements helps with that, and of course we all know that we do that routinely. It's normal to get some ECG changes in pregnancy too. Sinus tachycardia, the pulse rate can go up by about 20 beats per minute in pregnancy. That's normal. You can get mild ST segment changes on your ECG. Left or right axis deviation. Left axis deviation is the most common. Again, in late pregnancy, the pregnant uterus just pushes the heart across, up and to the left, so that's why you get axis deviation. And you could also get ectopic beats quite frequently. They're very common. And if you listen to a heart in pregnancy, some of the things that we would think were pathological in a non-pregnant lady are actually quite normal. It's normal to get increased splitting of your second heart sound. It's normal to get a third heart sound. Fourth heart sound is not normal. That usually indicates something is going on. Mid-systolic murmurs are common, flow murmurs. The important point here is that diastolic murmur is not a normal feature of pregnancy. So if you hear a diastolic murmur in a pregnant lady, it indicates pathology. You can also get some continuous murmurs that are associated with pregnancy. These things called venous hums and mammary souffles, which you get over the breasts of breastfeeding ladies. Just a continuous pansystolic, pan-diastolic noise when you listen. Stenotic murmurs, some mitral stenosis and aortic stenosis increase during pregnancy, but the regurgitant murmurs actually reduce, and that's related to that reduced systemic vascular resistance, actually favouring forward blood flow, if you like. So that's the reason why regurgitant heart lesions tend to do better in pregnancy than stenotic lesions. Echoes also change a bit in pregnancy, so it's important if you can to have pre-pregnancy echoes in ladies with rheumatic heart disease. I would hope that they would all have had echoes, but it's actually not the case in reality. We'll see that with a couple of our cases, but you do get those slight echo changes that are due to pregnancy. This graph on the left shows that everything is worse on an echo during pregnancy than after pregnancy, so if you do an echo in pregnancy, it doesn't necessarily always reflect what's going on before pregnancy. The graph on the right shows what happens to you if you have got rheumatic heart disease. If you look at the black bars, you'll see if you've got severe rheumatic heart disease, you have about a 75% chance of something going wrong, either with yourself as the mother or with your fetus during pregnancy. So these are not insignificant conditions. So this is our first case, a 23-year-old lady from a community called Balgo, which is in the Tanami Desert. I'll show you a little map in a moment so you know where that is. She does what's pretty typical in our region and presents for her first antenatal visit at 20 weeks. She drinks a significant amount of alcohol, she's very mobile, she moves around the whole Kimberley region quite frequently, quite hard to track down sometimes. But we do believe she had rheumatic fever as a child, and there's a mentioned in the file that she might have had mild mitral stenosis at 14, but no one can find an echo report in the file. But you listen to her heart and she's got a pansystolic murmur, she's got a mid-diastolic rumble and probably an increased second heart sound. And what she's got is severe mitral stenosis. So this echo shows a severely stenotic mitral valve, thickened mitral valve, and a big dilated left atrium. So just to give you a feel for where Balgo is, so you can see Balgo's the black dot with the orange name there. It's 1100 k's by road from Broome. It's about 800 k's by road from Kununurra. The nearest town is called Halls Creek, which is 240 k's away. It takes about 3.5 hours to drive from Halls Creek to Balgo down the Tanami Road, which is pretty rough and closed for a lot of the year during the wet season. Halls Creek does not officially do deliveries. Unofficially it does, of course, because people front up in labour, but they're not supposed to do deliveries at Halls Creek. In the Kimberley, people can deliver in Broome, Derby and Kununurra, and the neonatal nursery is actually in Derby, which is probably about 850 k's from Balgo, something like that, just to give you all a bit of a feel for what we're up against. That's Balgo from the air. It's on the edge of some beautiful desert breakaway country. It's actually a lovely area. It's a Catholic mission community, so that's the church. That's the photo that we'll all be fairly familiar with. That's Balgo housing, Balgo vehicles, very typical central Aboriginal community. And Balgo girls. It's a very young community in general. They're very good artists, a lot of the people in Balgo. They've got a very famous art centre. These figures are raw numbers, they're not percentages. They're from a survey that Graham did in the Kimberley 3 years ago, something like that, 2 or 3 years ago. Yeah, and we've redone it since, but these are figures from a while ago, just to illustrate that the majority of our Kimberley women with rheumatic heart disease are indeed of childbearing age. That's the point on this slide. Put another way, probably about 5% of our antenates have got rheumatic heart disease, something like that, we think. So the questions with this lady is, well, is her valve lesion important? What do you think? Yes, that's a pretty easy question to answer. Definitely important. What's the prognosis and how should we manage? And there's 3 aspects to that. Through the rest of her pregnancy, how should her delivery be managed? And then what should we do with her afterwards? Well, what's her risk? Well, basically what this slide is showing is that just about all valvular heart disease, regardless of how symptomatic it is or not at presentation, will get worse during pregnancy. And that's exclusive really of what valve lesion is, not just mitral, it's also aortic valve disease, pulmonary valve disease, etc. 74% of them will get clinically worse. The main problem is heart failure and arrhythmias. About 35% of them will end up needing to be hospitalised at some stage during pregnancy. The outcomes for babies, there's an increased risk of preterm delivery. They have smaller babies, so they get intrauterine growth retardation and reduced birth weight. The worst lesions to have in terms of the mother's heart is severe left-sided obstructive lesions, so mitral stenosis and aortic stenosis. That confers the biggest risk on the fetus and the mother. So principles of management, we'll work at how at risk she is. Ideally, we should be doing pre-pregnancy planning and counselling, and our third case will illustrate that, but oftentimes we don't see these ladies until they're already pregnant. You need to decide how you're going to manage the rest of her pregnancy and where that management will occur, and also how she's going to be managed during delivery and where that will occur. Of course. Okay, yeah. Okay. In actual fact, Graham managed this lady rather than me. This is one of Graham's cases, but I can answer whether she was on pre-pregnancy prophylaxis. Yes, she was supposed to be, but she was incredibly sporadic at attending for her prophylaxis. I don't know whether she'd had any pre-pregnancy counselling, but she did have a note in her file that she had rheumatic heart disease when she was younger, I believe. Yeah, exactly, but it wasn't obvious. That's it. The other problem with that is she was a mobile patient as well, so somebody else might have given the prophylaxis, who knows, and as Graham says, she wasn't flagged by them as a priority patient. So just to repeat the question for the filming, well, the question was, where are the referral centres for cardiology assessment and interventional cardiology? Perth, 2,500 kilometres away. Big deal. We do have visiting cardiologists, and they do actually go to this community, but they only go there, they come to the Kimberley 8 times a year, they go to Balgo half of those times, so they go there 4 times a year for half a day. So look, the way we stratify risk, I'll go through this fairly quickly so we can get to the other cases, but obviously the echo is important, her symptoms are important, her past obstetric history, if they've had a previous baby, which this girl hadn't, but past obstetric history, what problems did they have during the antenatal period at delivery, what problems did the baby have, has the valve lesion got worse since then, basically. We might just brush past this. Basically just to say that severe left-sided lesions or left-sided lesions with significant symptoms, particularly stenotic lesions, are the most problematic. Aortic stenosis does worse, mitral stenosis does pretty badly, the regurgitant lesions do better. This study actually shows 4 things that you can use to work out how at risk your lady is during pregnancy, and it's quite helpful. You score 1 point for each of those things in the box. So if they've had a prior cardiac event or arrhythmia, so stroke, TIA, pulmonary edema, if they've got class 2 symptoms or cyanosis, class 2 symptoms or worse, or cyanosis, if they've got a significant left-sided obstructive lesion as detailed on the slide, or left ventricular dysfunction with an ejection fraction less than 40%. Each of those scores 1 point. And if you score more than 1 point, you're in trouble, is what that shows, basically. So the conclusion from this paper was if you score 1 point or more, you should really deliver in a big regional centre. You shouldn't be delivering in a community hospital. Converse being that if you score 0, you can safely deliver in your community hospital. But, of course, most of our ladies, I suspect, would not score 0. Just to let you know what drugs we can use in pregnancy, if you read the MIMS, it says that just about everything is contraindicated, but non-selective beta blockers like labetalol are okay. Obviously methyl-dopa for blood pressure is okay. We do use metoprolol. Frusemide is okay, digoxin is okay, vasodilators are okay, heparin's okay, and we'll come on to the warfarin story at the end. ACE inhibitors and angiotensin blockers are bad news. I mean, a lot of our ladies are on these for diabetes, diabetic nephropathy, hypertension. You need to stop them prior to pregnancy if you can. If a lady lobs up pregnant on an ACE inhibitor or an ARB, just stop it as soon as you possibly can. Cardiopulmonary bypass in pregnancy is also bad news for the fetus. If you have to go on to bypass, your baby has a 1/3 chance of dying. So you really want to avoid surgical procedures that involve bypass during pregnancy. So back to mitral stenosis. Gets worse during pregnancy symptomatically because the pressure gradient increases due to increase in heart rate and increase in blood volume. That causes worsening breathlessness, paroxysmal nocturnal dyspnea, they go into pulmonary edema, they can go into AF. So general management principles comes back to dealing with it before pregnancy if you can. If you can't and you've got a pregnant lady with mitral stenosis, you can beta block them to slow the heart down, and that will help reduce that increase in gradient. Obviously avoid anemia, anything else that can cause added stress to the heart. Quite often they do need admission during the 3rd trimester. If they go into AF,